Hello and welcome to Clinical Path. Today's topic is homeostasis and adaptation of the cardiovascular system. And a good way of thinking about this is to use the homeostatic model that equates an organ to being a biomachine. And to run any machine, you have to maintain an operating output that stays the same despite changes of internal and external environment. And to do that, you must identify the essential functions of that machine. And then these can be maintained by having a regulated variable. So as a general model, we can see that a regulated variable has to be kept within a dynamic range which allows for optimal function. And this regulated variable has to be monitored by a sensor, which in turn reports to a controlling cell, which has an effector mechanism for maintaining that regulated variable within its optimal dynamic range. When one says, what is the essential function of the cardiovascular system? In fact, the body doesn't monitor cardiac output, it monitors tissue perfusion. And to do optimal tissue perfusion then, it has to have regulated variables at the level of the whole body or systemic system, at the organ level or tissue, and at the cellular and molecular level. At the system level, it monitors two regulated variables. The first of these is arterial pressure. This is monitored by baroreceptors, which are found in the aortic arch and the carotid sinuses. And these then signal to the medulla, specifically the nucleus tractus solitarius, which then uses as an effector mechanism the autonomic nervous system of the sympathetic and parasympathetic nerve systems. Other baroreceptors are found in the kidney, where the juxtaglomerular apparatus affects change in blood pressure by using hormones, specifically angiotensin II and aldosterone. A second regulated variable is venous pressure, and this is monitored at the level of the atrial myocyte and in the great veins. And when there's too high a stress on the atrial myocyte, it then deals with a hypertensive status by secreting atrial natriuretic peptide, which is the anti-aldosterone. The heart also monitors pressure at the tissue level. The regulated variable is left ventricular and diastolic pressure, and this is sensed by the ventricular myocyte itself, such that when it is overstretched, it contracts harder. So this response of contraction to the amount of preload is called the Starling effect, and we'll discuss that more when we get to congestive heart failure. At the cellular or molecular level, there are multiple regulated variables. These include hypoxia, bradykinin, prostaglandins, and other parameters. But in fact, there's also a mechanical monitor of shear stress, the actual resistance of flow along the surface of the cell. And the sensor cell for all of this is the endothelial cell. And it locally then can release signals such as nitric oxide, prostaglandins, and endothelin that are all going to be regulated by the smooth muscle cell, which is going to respond by contracting or relaxing for vasoconstriction or vasodilation. Let's go into detail and look at the systemic regulation of blood pressure. And an easy way to do that is to think about the body's response to hypotension, because this is a pretty common clinical state. Blood pressure equals cardiac output times total peripheral resistance. Cardiac output equals heart rate times stroke volume. And stroke volume is proportional to preload, contractility, and afterload. Let's look at the baroreceptors that we find in the arterial system. So this is going to include the aortic arch and then the carotid sinuses. The arch neurons are going to signal the brain through the afferent branches of the cranial nerve, and the carotid sinuses are going to signal through the glossopharyngeal nerve. And these are going to signal back to the medulla. Here's the optic chiasma coming in at the base, to the pituitary gland, mammillary bodies, and then down into the midbrain, pons, and the medulla. This would be our corpus callosum, Fornix, this would be our hypothalamus. In the medulla, we see the cranial nerve 9, cranial nerve 10, and then at the medulla itself, there is the cross-section showing us the nucleus tractus solitarius. And this can then signal through the sympathetic nervous system or through the parasympathetic nervous system to increase or decrease. In this case, we're talking about hypotension, so it's going to be the sympathetic nervous system, which we can think is running along the back of the body from T1 through L2. And this is going to signal three key organ systems: the heart, the adrenal medulla, and the kidney. So let's look at each of those in detail and follow it through completely from the sympathetic nervous system to the cellular mechanisms. In the heart is going to be the sinoatrial node. The signal at the cellular level is going to be to the B1 receptor, which is a G-coupled receptor, and it's a GS-alpha, which means that it's going to stimulate adenyl cyclase to make cyclic AMP, and cyclic AMP to protein kinase A. And protein kinase A is going to affect the ion channels of the conducting cell. And that we can see through the depolarization, which starts with a maximum negative potential of minus 60 millivolts. And notice that that's less negative than is required for the fast sodium channels of the contracting cell, which trigger at minus 70. And the threshold potential then becomes minus 40, which is when we open our calcium channels. So in the normal pacemaker cell, we have the inward channel, the IF, and when it depolarizes to minus 40, we open our calcium channels, and then we repolarize through the potassium channel. What is the effect then of beta-1 stimulation? It is going to lower the needed threshold potential, and it's going to increase the rate of climb of the diffusion. That is going to increase heart rate, and that's useful because an increase in heart rate will increase cardiac output with an appropriate response of the blood pressure. The second heart cell that's going to respond is the cardiac myocyte, the contracting cell. Again, this is going to be on our beta-1 G-coupled receptor, and it's still going to be GS-alpha, which through adenyl cyclase and cyclic AMP is going to produce protein kinase A. But now the effect is going to be on the calcium signal. So if we have a voltage-gated calcium channel creating our original calcium signal, this is going to be calcium-induced calcium release from the smooth endoplasmic reticulum, which is going to stimulate the ryanodine receptor to give a massive output of calcium, which is going to affect our troponin C and allow for the actin active sites to interact with myosin and give us a contraction. This is going to be re-pumped in through the smooth endoplasmic reticulum calcium ATPase, which itself has an inhibitory protein of phospholambdin. Protein kinase A from our beta stimulation is going to increase the calcium coming through the voltage-gated calcium channel, and it's going to inhibit our phospholambdin. And that overall effect then is going to be to increase the intracellular calcium, and intracellular calcium is proportional to our contractility. Increase in contractility will give us increase in stroke volume, and then to an increased blood pressure. The second organ to consider is going to be our adrenal medulla. This is directly stimulated from the nucleus tractus, and it's going to release catecholamines, about 80% epinephrine. And catecholamines are going to go to our blood vessels, where they're going to have the alpha-1 receptor, a GQ receptor. The GQ receptor is still a G-coupled receptor, but now GQ goes through our phospholipase C, and it increases a DAG, and it produces an IP3. DAG is going to increase the calcium from the voltage-gated calcium channel. IP3 is going to stimulate the smooth endoplasmic reticulum to release calcium. Calcium plus calmodulin is going to stimulate our myosin light chain kinase, and that's going to increase our actin myosin interaction and give us contraction. The effect then of alpha-1 stimulation is constriction of the peripheral vasculature, and increase in TPR is going to increase our blood pressure. The second effect of the catecholamines is, remember, that they are systemic, and so they're also going to increase the beta-1 receptors of the heart. The third system we want to think about is going to be our kidney. And the kidney is going to directly stimulate the juxtaglomerular apparatus of the nephron. And here is our macula densa of the distal convoluted tubule. Direct stimulation by the sympathetic nervous system is going to release renin to angiotensin 1 through ACE to angiotensin 2 and then to aldosterone. Aldosterone is going to go to the principal cell of the collecting tubule. It's going to go into the nucleus itself, and it's going to increase the epithelial sodium channel to increase sodium. There's going to be two different effects of activating the RAS system. The first is that angiotensin 2 has its own receptor in the blood supply, which is GQ, so it also is going to increase our total peripheral resistance. Aldosterone is going to increase sodium, which is going to increase our blood volume. Increase in blood volume is going to increase preload and result in an increase in blood pressure. So note this idea of completeness. We can start with an example of a low blood pressure, and we can follow it through from organ to tissue to cell to ultrastructure to molecular. Local regulation of blood pressure is done at the level of the endothelial cell. The endothelial cell we can think of as regulating the local blood pressure through its interaction with the smooth muscle cell. If we start with our endothelial cell here, we can see that it has a number of receptors on the surface to things like prostaglandins, ADP, bradykinin, and in addition, it can respond to the friction of the blood flowing over it, which is our shear force. These are going to increase in the cell our nitric oxide synthase, and this is then going to convert an arginine to a citrulline. That's going to produce nitric oxide. This is going to diffuse out of the cell to our neighboring smooth muscle cell. Nitric oxide is going to increase the activity of our myosin light chain phosphatase. The effect of that enzyme on our actin myosin head, it's going to take the phosphorus off, it is a phosphatase, and send the contractile head into a relaxing position. Nitric oxide then has a relaxing action. And you can compare that to what we just discussed on the contraction side, because here we have our GQ receptor, and this can be to either alpha-1, angiotensin 2, or the V1 receptor of ADH. And now we can see that the increase of calcium plus the calmodulin is going to increase the activity of myosin light chain kinase, which is going to add the phosphorus and create active interactions. Hypotension is a good way of thinking through regulation of blood pressure, but adding drugs in is also an excellent way of understanding the actions of the body's regulation. Let's draw ourselves the organ systems and then see where our drugs that are used widely both in congestive heart failure and hypertension interact on our organ through molecular model. We're going to start where everything reports up here in the CNS. So here's our brain, and we can see in here we have our corpus callosum and our fornix. And then coming down out of here, we have our optic chiasma to our pituitary, mammillary bodies, and then it's going to come out midbrain, pons, and into our medulla, into the spinal cord. And the spinal cord, as we've discussed, is going to output through the sympathetic nervous system. If we have a hypotensive episode, hypotension centers in the hypothalamus release ADH. The baroreceptors are going to report to the nucleus tractus solitarius, which is going to stimulate our heart. So that's going to be our SA node, and then its effect on the contractile myocyte. Second thing to think of is our adrenal medulla, straight from the spinal cord itself. This is now going to release our catecholamines, which, as we've discussed on our blood vessels, is going to do the GQ for vasoconstriction. GQ can be angiotensin II, the V1 receptor of the ADH system, and the alpha 1 of the sympathetic nervous system. And then the third organ that's going to be our kidney, which is going to affect our juxtaglomerular apparatus of the nephron. And that then is going to activate our RAS system from renin to angiotensin 1, converted to angiotensin 2, and that's to aldosterone. Aldosterone is going to affect the epithelial sodium channel of the collecting tubule, and angiotensin 2 is going to affect the GQ receptor on the blood vessels. Let's compare that then to the effects of our basic drugs in pharmacology. Let's start with beta blockers. It's going to decrease heart rate from the B1 receptor of the SA node, and it's going to decrease contractility at the level of the myocyte. In addition, remember, catecholamines come out of the adrenal medulla, and the beta blockers are going to affect that as well. The second of our drugs is going to be our ACE inhibitors. And ACE inhibitors are going to block right here the conversion of angiotensin 1 to angiotensin 2. Third of our major drugs is going to be our angiotensin 2 receptor blockers. And that's going to be at the level of the GQ here, which is going to prevent the increase in our total peripheral resistance from the GQ type receptor on blood vessels. Spironolactone is going to block the effect of aldosterone at the level of our epithelial sodium channel in the distal tubule. A new major drug is going to be naproxen, and it's going to work at the level here of the effect of the atrial natriuretic peptides, which function as an inhibitor of aldosterone. And naproxen inhibitors then are going to increase the action of the adrenergic peptides. Diuretics work at two different levels. A is furosemide, which we use in congestive heart failure, is going to work here in the thick ascending limb at the level of the sodium-potassium 2-chloride receptor. Thiazides work at the level of the distal collecting tubule, where they block the sodium chloride exchanger. Our calcium channel blockers work at the level of the smooth muscle here, where they block the calcium signal of the voltage-gated calcium channels. When we talk about nitrates, which are going to be important with things like nitroglycerin, these are going to function at the level of the endothelial cell, signaling to our smooth muscle cell. Nitric oxide and vasodilation is induced. And then the last of our important drugs is going to be digitalis, which is important for increasing the intracellular calcium level of the cardiac myocyte, giving increased contractility and giving enhanced pump action. So the ability then to take all of our major cardiovascular drugs and place them onto this diagram is a really useful way of thinking through the molecular action. Adaptation refers to the response of the body when homeostasis is inadequate. Homeostasis is comparable to physiology and maintains the function of an organ through the normal variables of the day, whether there's fasting or increased exercise. And these are mostly neurohormonal. But what if there's a stress greater than can be responded to by homeostasis? So for example, you have primary hypertension or you have an abnormal cardiac valve. Something that exceeds the ability of the homeostatic mechanism to bring adequate function is called a stressor. And stressors cause a change in the cell and the organ, which is called adaptation. This is going to be a genetic signal that's actually going to restructure the proteins and the molecular architecture of the cell. It is a change in the nature of the cell itself. And this signal to the cell to make these genetic changes is mostly through cytokines. If this adaptation is not sufficient to restore normal function, and this can be a function of way too long an exposure or way too severe a problem to fix, then this is going to lead to disease. Disease can be mostly compensated, meaning the patient can do normal everyday actions, just not the highest level of performance, or it can be progressive and lose so much function that there's inadequate performance even at rest, and that is called failure. And in the heart, we call adaptation remodeling. Heart cells cannot divide. And so this means their only compensatory response is hypertrophy, meaning the actual structures in the cell increase in number. This means an increase in sarcomeres. We also get a change in the nature of proteins so that we get a fetal protein pattern. And this occurs in two basic ways. The first is going to be if there is an increase in the afterload. And this can be caused by things such as aortic stenosis or primary hypertension, and it's going to give an architectural pattern grossly of what is called concentric hypertrophy. If we form a mental image of this, we can hear the Z lines which define a sarcomere, and here are our actin proteins anchored on it with the myosin chains running through. And when we see response to afterload, we're going to get a parallel proliferation, so that we're going to see an increase in the number of sarcomeres, increasing the thickness of the sarcomere. Grossly, we're going to see about the same diameter, but we're going to see this marked increase in the thickness of the wall. The problem with that is going to be that that's going to increase our diastolic filling pressure, and it's going to decrease our stroke volume. But it does help the problem of the heart. And Laplace's law states that the pressure that the heart needs to generate to open the aortic valve is created by wall tension of the wall of the ventricle, and that is proportional to the radius of the heart over the thickness of the heart. If we have to increase the wall tension, we can see that we can decrease the necessary tension that we need by here increasing the thickness. So it does solve the tension problem, but you can see the problem is we pay a price for it, which is we have an increased diastolic pressure, so it's harder to fill the heart, and we have a decreased stroke volume. We get a different solution if there's an increase in the preload. That could be mitral regurgitation or the increased blood volume of chronic renal failure. This is going to give us a different situation, because now when we look at the Z lines, we can see here are our actin structures with our myosin lines. Now we're going to increase our sarcomere in series. Here's our Z line with our actin. Now we're going to get an increase in the number of Z lines. And that's going to give us a different architecture when we look at the heart of eccentric hypertrophy. So now our heart is going to be bigger and dilated with a relatively thinner wall. And that solves our problem because it gives us an increased stroke volume to deal with our increased preload. The problem that we face is we've increased the radius. And so when we come back to Laplace's law, you can see we've had to increase the radius, which means we're going to have to increase the wall tension, which can lead to failure over many years. So remodeling responds to a stressor, a condition that exceeds normal physiology, and the heart compensates to solve the problem, but it's only a short-term solution because it carries trade-offs that are not sustainable over long periods of time. And this unsustainable demand on the heart leads to what is called irreversible progression. When we have the stressor and we have to actually change the structure of the heart, this is going to be through cytokines and through maximizing the homeostatic mechanisms, which is going to be constant stimulation by the sympathetic nervous system. And over many years, the problem with this is it leads to myocyte apoptosis and to rechange of the extracellular matrix so that we get an increase in extracellular matrix collagen, which leads to fibrosis. This is going to lead to a negative spiral because we're losing myocytes, so the remaining myocytes now have to have an increased function, and we've created stiffness with all of that collagen so that we have a decrease in contractility. And now when we take a look at our patient function, if this is our cardiac function on this side over many years, what we're going to see is this progressive downhill spiral of function until we get failure at rest, which is called congestive heart failure. A key idea in the treatment of congestive heart failure is to prevent irreversible progression. We want to differentiate the drugs that actually change the natural history, meaning they give longer survival, from those that are only treating symptoms. So when we talk about the drugs that alter natural history, they're mostly the ones that undo the neurohormonal signals. So this is going to include our beta blockers, ACE inhibitors, and along with them the receptor blockers, and any of the anti-aldosterones. So this is going to include spironolactone and the neprilysin inhibitors. The drugs that only treat symptoms are going to be the diuretics and digitalis. There are a number of key ideas we have to take out of the homeostatic and adaptive regulation of the heart. The first thing is to think through how the body monitors tissue perfusion through various regulated variables at the level of the system, tissue, which is our Starling phenomenon, and the cell, which is going to be the endothelial cell. And then on to that, we want to talk about the effects of adaptation, again, at the system, the tissue, and the cellular level. When we talk about system regulation of blood pressure, make sure that you can trace that all the way from the sensor cell, which is going to be our baroreceptors, into the CNS, and then from that through the sympathetic nervous system to our three key effector organs, which is going to include our heart, adrenal medulla, and kidney with the juxtaglomerular apparatus. At the local level, this is going to be the key interaction of the endothelial cell with the local smooth muscle cell and nitric oxide to affect the myosin light chain phosphatase. Understanding the mechanism of our pharmacology drugs is really an excellent way of understanding all of these regulatory pathways. And then last, we've got to talk about adaptation, which in the heart is generally called remodeling. And there are going to be two different ways that the body responds through its hypertrophy. Concentric hypertrophy to afterload and eccentric hypertrophy to increased preload. And the key to treatment is to prevent this adaptation going into irreversible loss. And this is going to be mostly about finding ways to shut down the neurohormonal signal. So that brings us to the end of this discussion. Thanks for listening. We'll see you next time.